Today, we're going to tackle a condition that often feels a bit like a medical mystery, one where the clues can appear and then just vanish. We're going to piece that puzzle together and explain multiple sclerosis.
So, to really get to grips with MS, we're not going to start with some dry textbook definition. No. Instead, we'll begin with a person, because her story really holds the key to understanding this complex condition.
Right, imagine this. A 28-year-old woman walks into her doctor's office. For the last 3 days, she's had blurred vision in her right eye, and it actually hurts when she moves it. She also happens to mention that, a while back, her left leg went numb for a bit, but then it just got better on its own. Now, on the surface, these things sound completely random, don't they? But are they? What on earth could possibly connect them?
Well, to answer that question, we need to look beneath the surface, under the bonnet, if you will. The link between these strange symptoms isn't something you can see. It's happening deep within the body's own communication network.
The diagnosis connecting all these dots is multiple sclerosis, or MS for short. So let's break that down. It's chronic, meaning it's a long-term condition. It's autoimmune, which means the body's own immune system gets confused and mistakenly attacks itself. And what does it attack? Something called myelin, the protective coating around our nerves, which is why it's called a demyelinating disease of the central nervous system.
And this image shows you the core of the problem perfectly. On the left, you've got a healthy nerve cell. The signal zips along smoothly, protected by that fatty coating, the myelin sheath. The best way to think of it is like the plastic insulation on an electrical wire. But look at the right. In a nerve affected by MS, the immune system has attacked and stripped away that insulation. The wire is now exposed, and so the electrical signal gets disrupted, it slows down, or sometimes it just stops completely.
So this whole process really unfolds in 4 key steps. First, for some reason, the immune cells decide to attack the myelin sheath. This triggers a lot of inflammation, which strips the nerve of its protection. That's the demyelination part. Then, the damaged nerve can't send its signals properly, and that's what causes the symptoms. And over time, if this keeps happening, the nerve fiber itself, the axon, can be permanently damaged. This is what we call axonal loss, and that's what can lead to lasting disability.
Which, of course, brings us to a really critical question. If you've got this huge variety of symptoms, from blurred vision one day to numbness the next, how can doctors be so sure it's MS and not something else entirely?
Well, the absolute cornerstone of an MS diagnosis is a simple but incredibly powerful concept: dissemination in time and space. What that means is that doctors are looking for evidence of damage in different parts of the central nervous system, that's the space, which have happened at different points in time.
And here's what dissemination in space actually looks like on a scan. These bright white spots you see on the MRI are lesions. They're little hotspots of inflammation where myelin has been damaged. To be confident in an MS diagnosis, a doctor needs to find these lesions in at least 2 separate, distinct areas of the brain or spinal cord. That proves the damage isn't just in one place, it's widespread.
Okay, so that's the space part sorted. Now for the time component. Let's go back to our patient. Remember, she had a previous episode of numbness in her leg that went away. Now she's got a completely separate issue, blurred vision, a classic sign of something called optic neuritis. These are 2 distinct attacks, happening at different times. And just like that, you've satisfied the second half of the diagnostic criteria.
Now, to lock all this in, doctors have a few key tools in their toolbox. The MRI is the big one, of course, because it can literally show you the lesions. They might also do a lumbar puncture or a spinal tap, which lets them test the fluid surrounding the brain and spine. What they're looking for are specific inflammatory proteins called oligoclonal bands. You can think of them as immunological fingerprints that prove inflammation is happening inside the central nervous system. And finally, blood tests are absolutely crucial to rule out other conditions that can sometimes look a lot like MS.
So, once the diagnosis is confirmed, what's next? Well, while there isn't a cure for MS just yet, there are some incredibly effective strategies out there to manage the condition and really slow down its progression.
Treatment for MS really has 2 clear goals. The first is to deal with acute attacks or relapses when they happen. For that, doctors use high-dose steroids to basically put out the immediate fire of inflammation and shorten the attack. But the second goal, the long-term strategy, is all about prevention. And that's where disease-modifying therapies, or DMTs, come in. These are medications designed to calm down or re-educate the immune system to reduce future attacks and slow the disease right down.
But you know, managing MS isn't just about the big attacks. A huge part of the overall plan is managing the day-to-day symptoms.
We're talking about things like physiotherapy for muscle stiffness and spasms, a symptom called spasticity, as well as medications to handle nerve pain and the really profound fatigue that so many people experience. It's all about improving a person's quality of life.
Now, because the symptoms can be so varied, getting the diagnosis right in the first place is absolutely vital. And this means doctors have to become detectives, ruling out a whole host of other conditions that can look surprisingly similar to MS. This whole process is called a differential diagnosis. Doctors have to work through a list of MS mimics, which can include infections like Lyme disease, other autoimmune conditions like lupus, or even something as simple as a vitamin deficiency. A key one on this list is ADEM, which also causes a sudden attack on myelin. But it's usually a one-off event, often after an infection, very different from the recurring nature of MS. And that really highlights why that thorough investigation is just so critical.
The course of MS is different for every single person, but certain factors can give us a few clues about the long-term outlook. Favorable signs, things that point to a better prognosis, include having only sensory symptoms, like numbness during a first attack, or having really long gaps between relapses. On the flip side, early problems with movement or balance can sometimes point towards a more challenging disease course.
So, we've pieced together the puzzle of MS, from a patient's first confusing symptoms all the way to the complex biology happening inside the nervous system. But getting your head around the diagnosis is really just the first step. It leaves us with a final thought. Knowing that so much of the damage in MS is invisible from the outside, how can we, as a society, better support those who are navigating this unpredictable, lifelong journey?